I'm really excited about our final speaker of the day. Marianne Udow-Phillips is a faculty at University of Michigan School of Public Health and the Ford Public Policy School. So she's got a little bit of experience with this. She is the former director of CHRT, the Center for Healthcare Research and Transformation. She previously was the director of the Michigan Department of Human Services. She has also been a senior vice president at Blue Cross Blue Shield of Michigan. All told, having over 30 years of experience in public health and health policy, and serves on multiple boards around the state for various communities. So she's here to wrap this up for us and summarize some of what we learned. So thank you.
So thank you, Dave, and thank you all, for those of you who have made it through this marathon session with just so much incredible information. Thank you for an incredible conference. And I am going to try to wrap this up and give you a little bit of perspective, and I'm going to try to do something a little different. You've been crammed full of information throughout the day, and I'm going to try to take a little bit of a step back and bring the connection to health policy as you see here. So this is going to be a little bit of a back to the future talk, and I'm going to start with a little bit of history to remind us where Medicaid actually came from. And then I will get to where we are today and what the future holds, and hopefully I'll pick up a few themes that weren't covered actually in the breakout sessions, at least that I could tell, and make some policy suggestions about where I think we could go and where we're likely to go in the near term. So I'm going to try to do all of that in about 30 minutes and get you out of here and back on the road with some fresh thinking, I hope. So why am I starting with a piece about the history and all of the framing around where Medicaid comes from? It's because if we don't understand the history of Medicaid, we will not understand the future of Medicaid either. We have to know that the issues and the growth and the framework and the philosophy behind Medicaid are still with us today. And I think you will see that as we talk about what the policy issues are that are in debate as we speak in this very moment, right? So let's start. So we're going to go back to the Elizabethan era. I told you, some of you, that we were going to go way back there, right? Back to the late 1500s, early 1600s, and remind ourselves that the foundation of Medicaid is in the concept of the poor laws that began in Elizabethan England. And what's very important about understanding this is where the concept of the worthy poor comes from. That concept, as you'll see, is still alive and with us today. So if you look at those poor laws and you see the categories that those in poverty were placed in Elizabethan England, it includes the vagrants, the involuntarily unemployed, and the helpless, right? The vagrants were clearly those, and if you really look at that horrible picture, you will see how the vagrants were treated and what they were assumed to be. They were the ones that were felt to be able-bodied, but not working, not engaging, not productive in society, and yet able-bodied. And this framework was brought, the colonists who came to America brought that framework with them, and it laid the foundation for all of our poverty policies in this country, frankly, through today. So Medicaid came into the first framing for Medicaid, the first steps in Medicaid came to be in 1950 with the public assistance amendments to the Social Security Act. And that's the first time that there were, in fact, federal matching funds to states to make payments to vendors. Those of you who are providers in the room, you were actually known as vendors in those days. That's where the payments meant. So it was the beginnings of the foundations of the idea that the federal government and the states ought to be involved in making medical assistance payments for those in poverty, at least for some of those in poverty, and in this case, clearly for those who were considered worthy, as previously noted. The ones who are considered worthy, by the way, at this point, were those who are old age, blind, disabled, and mothers with children. So a very limited segment of the population, those are the ones that were considered either helpless, the children, or the involuntarily unemployed. Wilbur Cohn, who actually has a long history with Michigan, is the dean of the education school at the University of Michigan, as well as many other things, was the architect of Medicare and Medicaid. And Wilbur, you can read his piece at your leisure about how Medicaid came to be. But Medicaid was always seen as an incremental step forward to the journey to universal health care. Now, we don't have universal health care today. There are many reasons we don't. And frankly, many policymakers today would say that we made a fundamental mistake in thinking that this would be a gateway to universal coverage, particularly Medicare, because what actually happened was the pressure for universal health care was relieved by having these two stopgap measures that really never totally filled the gaps. But it took a lot of the pressure off. But Medicaid was seen as a beginning, as a step forward, never seen as the end, at least by Wilbur Cohn, in those early years when Medicaid was passed in 1965. And of course, one of the most fundamental things, and something that is still very alive in this moment, that happened in Medicaid's history was in 1996 with the passage of PWORA, which eliminated the Aid to Families with Dependent Children program in favor of the Temporary Assistance for Needy Families program, the cash assistance that we provide to those in poverty. Up until 1996, Medicaid and public assistance, aid to families with dependent children, were intertwined, were intimately connected together. In 1996, with the welfare reform debate that occurred in Congress, the move to change fundamentally how we think about welfare, and if you go back, if you're interested in poverty policy, and I know several of you here are, just go back and read some of those debates about what happened with federal poverty policy. It was a very complicated time, lots of debates about whether we were moving forward or moving backwards, and I think if you care about poverty, most of the data shows we actually move backwards in terms of helping people out of poverty with TANF. However, TANF specifically established the public assistance funding to states as a block grant. And the debate was very much about whether Medicaid should move down that same path as well. It did not. And it did not because President Clinton at the time said he would veto any effort to change medical assistance to include a block grant approach. So philosophically, already we begin to see in 1996 a distinction between the ways that we support individuals in poverty with programs like public assistance, food assistance, et cetera, and medical care. We begin to treat medical care as something different than those programs, something that is about providing a safety net for medical services, care for medical services that is not structured at all in the same way that cash assistance is. However, the debate was very hot at this point. And the goal to shift Medicaid to a block grant, to make it look like TANF, is not gone. It continues today, and you'll see that as we go a little bit further into our recent history with Medicaid. The most fundamental change in terms of Medicaid happened, of course, in 2010, the most fundamental change since the passage of Medicaid in 1965, and that is with President Obama's signature on the Affordable Care Act. The Affordable Care Act did more to change this founding philosophy of Medicaid about coverage for the worthy poor than anything that preceded it, right? So the change in the Affordable Care Act, at least as it was envisioned by its framers, was to move Medicaid away from a program that provided categorical eligibility to limited numbers of individuals based upon their status, to a program that was based solely on income. Now we know it's more complicated than that. We know that there are a whole variety of other elements that actually still keep some of that old framework in place, even in states that have done the expansion. But the basic philosophical change is fundamental. Now, the framers did not envision what the Supreme Court would decide in 2012 that meant that Medicaid expansion became optional for the states. And so in America today, we actually have a mixed model of Medicaid where you have a number of states, 10 states, in the country who still have this distinction that Medicaid is there for the worthy poor, not for everyone based on income, right? And that is something quite significant to understand, because there is a very strong belief structure in this country that exists that healthcare is not a right, that healthcare is a privilege, that healthcare is, and that Medicaid is a program of dependency. And one only has to look at Arkansas, a state that tried to implement work requirements for Medicaid, the first state to implement work requirements, the only state where we actually have an experience with work requirements. And governor of Arkansas, Sarah Huckabee Sanders, who was eager, I was just in the session on the Medicaid redetermination process. Governor Sanders has plunged all in, eager, could not wait to do Medicaid redetermination, and publicly said that we need to get people off dependency, right? So a deep philosophical view by a strong percentage of our population that Medicaid is a program of dependency that needs to be short-term and needs to be time-limited. And we see the results as Arkansas has plunged forward on the redetermination process, and already 72,000 people have lost coverage under Medicaid in Arkansas. So the ACA framers saw it differently, but there are many in the country who still have that same view that Medicaid is no different from public assistance, and therefore should have a number of strings attached to it that we'll talk about. However, with that change in policy under the Affordable Care Act, of course, we've seen this tremendous growth in Medicaid. And you can see we're at about 84 million people today that are covered under Medicaid, and you can see the huge spike that happened after the passage of the Affordable Care Act and the implementation of Medicaid in expansion in 2014. And we've seen growth even in the states, set aside what happened with COVID, we've seen growth even in the states that have not done Medicaid expansion because of other elements of the law that did go into effect to simplify Medicaid enrollment. And so today, we have more than 20% of the US population covered by Medicaid. You heard earlier from Farah, a higher percentage, much higher percentage in Michigan, more than a quarter of our state's population covered by Medicaid. Obviously, it's higher in the states that have done Medicaid expansion than the states that have not, but still, the force and the power, and this is quite important to where we are in this moment, because Medicaid has become mainstream. Medicaid has become a huge part of any provider's practice. Medicaid has become a huge part of our community life, and Medicaid has become a huge part of our friends' and neighbors' health coverage. The stigma around Medicaid is much lower today because many more people are covered, and that does create political momentum for maintaining Medicaid in a way that it did not exist, I would argue, before the Affordable Care Act and the changes that happened with the Affordable Care Act. And so you see what happened in 2017 with the effort to repeal and replace. Yes, that's John McCain with his famous thumbs down on the effort that came very close to repealing and replacing the Affordable Care Act. The repeal and replace debate was really about Medicaid. If you look at the elements that were proposed in the 5 different proposals that were made to quote unquote repeal and replace the Affordable Care Act, they had a small element of repealing elements of the Affordable Care Act, but they were fundamentally about reshaping Medicaid. And most of them went back to that philosophy that was debated in 1996. Most of them tried to move Medicaid to a block grant program, a per capita cap program with many limits that would have been applied to Medicaid. And they failed, and I argue, and I think many have said, that John McCain's vote on this was because he was of course quite ill when he took this vote, because John McCain knew the importance of healthcare, right? He was going through his own personal commitment to healthcare, and because Medicaid had become so more deeply ingrained, he was afraid of what would happen in the country if we so fundamentally changed Medicaid. And so a big part of that thumbs down really did have to do with Medicaid, but the desire for fundamental change in Medicaid is not gone. What we saw after this were a whole raft of administrative policies put in place by the Trump administration that also attempted to revision Medicaid through the regulatory process. And most significant to all of that were the imposition or the encouragement of states to impose work requirements, right? And as I said, Arkansas was the first and only state that actually had the work requirements implemented, but 7 states, including Michigan, passed a requirement for work to be tied to Medicaid enrollment. Those actions were enjoined at a federal district court level, but it is important to understand, so they did not go into effect. Arkansas was pulled back, but it is important to understand that even though the federal district court's ruling was that work requirements were not consistent with the Medicaid statute, that case went to the Supreme Court and it was never ruled upon, right? Under the Biden administration, that case became moot. And so we have no decision, ultimately, at the Supreme Court level on whether or not work requirements are permitted based on the Medicaid statute. I will tell you that that issue is not dead and could easily be revisited by the Supreme Court, and I would not predict which way they would rule in this context. And so it brings us to today. And this very day, President Biden and Speaker McCarthy met again to talk about the debt limit. And in the House Republicans' debt bill, Medicaid work requirements figure prominently. The goals to revisit that debate in 1996, to go back to that Elizabethan framing of Medicaid as a program that is limited and one that is only for the worthy poor, still lives among many policymakers. And I would remind us that we, in this moment in Michigan, have a legislature that is extremely supportive of Medicaid, that repealed the work requirements in one of their first actions of the new legislature, right? That is doing everything it can to minimize the disruption from Medicaid redeterminations. But that could change tomorrow. That could change with the next election. The same thing in Washington, D.C. We already have a House majority that views Medicaid as nothing different from public assistance, that is trying to impose more limits on food assistance, on Medicaid. And again, we saw what happened in the last administration, where by regulatory changes, they saw Medicaid in a very different light than the current administration. So there is nothing sacrosanct here. These are all policy issues that have never been settled, because we as a country have never come to a conclusion about how we feel about medical care, whether it is a right or a privilege, right? So this is hot today. Everything that we hear that's being leaked out of the debt ceiling talks tells us that work requirements, at least for Medicaid, will not be part of it. But we don't know. And we know that it is still a very hot issue in the caucus, in the Republican caucus in the House. So that brings me to my final slide and the issues I want to conclude on, many of which we have talked about today, but I want to add a little bit, hopefully on points that haven't yet been covered, about where this history tells us and where this current moment tells us that we might be headed with regard to Medicaid. And I've divided these issues, as I said, we've talked about many of them. There are obviously others that relate to Medicaid, but these are the ones that I really wanted to speak to in this moment because they are the issues of most relevance as we are reflecting on where we are heading with Medicaid, I think, in this time. So there's 3 categories of issues here. There are the issues that I really have spent a lot of time in this history part talking about, which are the partisan issues, right? Those are the issues of work requirements, block grants, and caps or eligibility limits, some way to restructure Medicaid. And there is a strong segment of the Congress, of state legislatures, of states who believe very strongly in these elements. Right? We are very divided. And I will tell you, if you do public opinion polling on work requirements with Medicaid, it polls favorably. Right? It polls favorably. So the idea that the public, and of course it very much depends on how these questions get framed, but the idea that these issues are settled issues is simply not true. They will still be issues of debate, and it will entirely depend on what a state legislature or what Congress looks like or who the president is in terms of what happens in the future about Medicaid. So to the extent, so part of my message to you in this closing session is to the extent that you care about Medicaid policy, and I know everybody in this room wants Medicaid to work as well as possible, regardless of what your views are, it is incumbent upon you to engage in the political process, to engage with your voice in what you believe, because these issues are going to be decided by very vocal people who feel very strongly about it, and it's very important for those who are passionate and who understand Medicaid to speak as well. So whatever your views are, these issues will continue to be issues of debate and potential change. Now let me spend a few minutes on the bipartisan issues and hopefully make a few points that I did not hear made in the breakout sessions, so I didn't hear everything in all of the sessions. There are bipartisan issues, and that's the hopeful part of this talk, because there are things that actually in Congress that folks agree on, and there are things I think that those of you who heard Rep. Vanderwall talk earlier and Julie talk earlier, you'll hear them agree on a number of these things, right? So there are bipartisan issues. There are places where both at the state and at the federal level there is policy agreement that these are critical issues. They might have slightly different ways to approach them, but I think these are the areas where we will see action, and we've already seen some action. So let me say a word about long-term care. Long-term care is such a critical issue within Medicaid. And frankly, as you well know, Medicaid is the only payer of long-term care services and supports, the only, not only public payer, the only payer of long-term care services and supports other than some private actions, right? And that's not going to change. In the Affordable Care Act, there was a provision called the Class Act that was designed to provide broader coverage for long-term care outside of the Medicaid system. That is the one of the very early and very few bipartisan actions where that section was repealed. It was Teddy Kennedy's dying wish, actually, to include coverage for long-term care as part of the broader coverage that we have for health care in this country. This particular section and the design of it had a number of technical issues, which were the reasons why it ultimately was repealed. But it was. And there's nothing on the horizon, and I hear from Medicaid directors, I don't think Megan's still here, but I hear from Medicaid directors across the country how frustrated they are that Medicaid is the payer of last resort for long-term care. But that's the reality, and it's going to stay that way, right? So we have to figure this one out. And not only is it the reality that Medicaid is going to continue to be the only payer for long-term care services and supports, but the demands are only going to go up, right? We have 70 million baby boomers coming in to the aging period where they will need supports and services. About 30% of them are in poverty. Most of them will be dual eligibles. So the pressure on Medicaid, on long-term care, is only going to increase. There was a long discussion in the breakout session earlier about the state's path with regard to DSNPs. And a lot of focus in that discussion about behavioral health. I'm going to talk about behavioral health in a moment. But I really want to encourage us to think beyond behavioral health in this realm and to focus on how do we help our Michiganders get more care in the home and community. How can we think more creatively about how we provide long-term care services and supports? Dave, in that session, noted that was one of the primary motivations for the state in moving down this DSNP path. We have, as a state, a higher rate of our senior population in institutional care than most other states. We have opportunities. Can we think creatively about the PACE program. The PACE program in our state and across the country. It's a fabulous program. It's a fabulous program. But we're serving less than 6,000 people in our state in PACE. Is there a way, yes, a call out to PACE. I love the PACE program. Is there a way that DSNPs and PACE can work together? We have a whole raft of programs at the state that provide services for long-term care, but they don't integrate. They're not a thought-through continuum. It's something the state's involved in right now. Can we think about these services, these programs, as a continuum so they build on each other, they partner together? Last, on long-term care, we have a long-term care system that is complex and confusing, and if you've talked to any of those in need of long-term care services and supports, they don't know how to navigate it. We need, in our state, a conflict-free option center. We need a way to help consumers in our state to navigate the long-term care system in a way that they can understand and know their choices. That does not exist in our state today. And though the AAAs do a tremendous job, there's variability across the state. We need to build a system that helps our seniors to navigate this very complex system. Behavioral health. We talked a lot about behavioral health and the CCBHC and the new models and the new money that integrates care. We had a huge debate in this state about integrating financing for behavioral health, and I don't think that was figured much in a topic in the behavioral health discussion today. And I would say good, because we need to move beyond that discussion about integrating financing, and we need to figure out how to integrate care. There are tremendous opportunities for managed care organizations, community mental health, private providers of care to work together. We all have the same goals. We have more people in need of behavioral health services than we have capacity to serve. We have tremendous impact on our healthcare system because of behavioral health needs that are gone unmet. We need to partner and collaborate together to meet the behavioral health needs of our communities. Prescription drugs. We have to think about the policy issues that are being actually developed at the federal level and their impact on Medicaid. And I want to just do one very quick word to give you an example of why following federal policy, not just state policy, on prescription drugs is really critical. You may all have heard that Eli Lilly and a number of other manufacturers is voluntarily reducing their payments from consumers for insulin drugs to $35, right? They got a lot of plaudits from the public sector, from consumers and others for voluntarily agreeing to that. Why did they do that? They didn't do that out of the goodness of their hearts. I wish I could say otherwise. They didn't do it because they were being good citizens. They did it for financial reasons because of Medicaid. Because one of the little-known provisions of the ARP, this predates the Inflation Reduction Act, is to lift the cap in the Medicaid drug rebate program so that, in fact, if Lilly and the other insulin drug manufacturers did not lower their price to $35, they would have been paying more to state Medicaid programs than the entire revenue that they would have earned for those drugs. This was entirely a business decision to do that. But the unintended consequence is that, in fact, state Medicaid programs may end up paying more for insulin than they had anticipated because of those changes. So following what happens at the federal level, lots of debate about PBMs, lots of changes on the road, that has to be essential. And last but not least, I want to say a word about social determinants of health. You notice I put this in the unclear category in terms of its partisan focus. You heard a lot earlier from Farah and from others throughout the day about the commitment of our state to issues of equity, to issues of addressing social needs and social determinants of health. CMS, under Liz Fowler, their new models all focus on improving health equity. It's a phenomenal time if you care about those issues, which I care about deeply. But I again would say that there is not a uniform view of these issues. And it is a fragile support, similar to the issues in some quarters that I talked about at the very beginning. And to give you the example around this one, we've been doing some work and interviewing folks between public health and primary care. And we were talking to the folks in Indiana who got an incredible increase in funding for their public health, state public health even post-COVID. It was quite phenomenal. And the appropriations process chaired by a Republican who became a huge advocate for public health. And we interviewed them to find out how they did it. You know, what was the magic of getting more support for public health in a state where public health was severely challenged during COVID? And they said, well, we talked about rural health. We never used the word social determinants of health. Whenever we would say that word, they would shut down. Now, that is tragic that that is the state that we're at, but it was true, and they had to focus on other issues. I would encourage all of us in this room, and I am certain that there is 100% support for a focus of Medicaid on social determinants of health, on social needs, and on equity. I would encourage us to, while focusing on those issues from the ethical and the perspective of reducing disparities, that we also build our business case for doing so. We have to be mindful that not everyone agrees, and that we have to move forward in ways that others can hear and where we can have that civil dialogue. So I want to be hopeful about the future of Medicaid and end on the most positive note, which is that with 25% or more of our state's population in Medicaid, with those of you in this room committed to Medicaid as never before, I believe Medicaid is a permanent part of the fabric of the future. But what it looks like will depend on us. And what it looks like will depend on your voices, your actions, in partnership together. And that's where I hope we can move forward. Thank you very much.